Dear colleagues, friends, diabetes advocates in Yemen, it's a great honor today to speak to you. I'm Peter Schwarz, Professor for Prevention and Care of Diabetes and President of the International Diabetes Federation. And what I would like to do with you is to discuss aspects of prevention of diabetes, which is one of the hot topics for me as the International Diabetes Federation or as President of the International Diabetes Federation during my presidencyship. So preventing type 2 diabetes, why, when, and how, I would like to take 15 minutes to discuss with you. So again, a very warm welcome with a lot of faces of people living with diabetes. And I truly believe that those people living with diabetes, especially in your country, especially in your region, especially in other low and very low income countries, require a better quality of life. It require better accessibility and availability of diabetes care. And this is what I will fight for as president of the International Diabetes Federation. Currently, we are talking about 589 million people living with diabetes on Earth, and these are data from the most recent diabetes atlas, which we have released at the World Diabetes Congress in Bangkok. But last World Diabetes Day, so 1 year ago, the WHO has released other data and is talking about 800 million, and this year actually 830 million people living with diabetes on Earth. So why are there so many different numbers? WHO having much higher numbers than IDF. Both numbers are right, but both numbers derive from using different diagnostic criteria for diabetes. One of the challenges we have to address in the future to harmonize the criteria to diagnose diabetes worldwide. But what does these numbers tell us? In my eyes, this is an urgent call to action. We have to understand better where diabetes is coming from and where diabetes is. 83% of people living with diabetes come from Pakistan, Bangladesh, India, and China. So 4 countries with a majority of people living with diabetes on Earth. But the biggest majority of people living with diabetes come from low and very low income countries. And the special challenge in this environment is that the complications of diabetes are very high. So the diabetes is related or associated with a high morbidity and mortality in this environment. And this is what we have to address as International Diabetes Federation. But there are also new determinants of diabetes. If you're looking at this slide, it shows you the conjunction of air pollution and diabetes diagnosis. We know that air pollution is related to cardiovascular disease. There are good studies showing this. But today we know, for example, if you stand behind a diesel car and you take some deep breath, then you find medium-sized particles out of the diesel engine 2 weeks later in the insulin-producing beta cell. And also in other endocrine cells. So what does it mean? We don't fully understand, but in cell culture, it impairs insulin secretion by 30%. So air pollution, especially in low and very low income countries, might become in the future a determinant of diabetes development. And if you think about cities like Delhi or Mumbai or Chennai, you can understand that this can have a relevant public health impact for those cities. But if you ask, what is the main determinant of diabetes development? Because we could say there are so many factors contributing to diabetes risk. What would be the main determinant? Because if we tackle this, we would have an impact. And the main determinant is actually very easy. It's the consumption of fried carbs. Today we know it's if you fry carbs, and you have a lot of lekker example here on this slide. If you fry carbs at a temperature of above 130 degrees Celsius, you build bonds between glucose and fat. And of course, you are eating this then. And this bond between fat and glucose, the body needs a lot of energy to break it down. And if you continuously have an influx of glucose or carbs, there's no need to break this down, and the body will store this. And where is he storing it? In the liver. And this is the main determinant of the development of MAFLD and MASH And especially if you go to India, this is probably the main driver of the diabetes prevalence there, but in many other countries as well, worldwide. So this is what I would count as a main determinant. And this maybe makes the story easier to think about prevention of diabetes, because this is something, if we can name it, if we can see it, we also can reduce it. But prevention can be very easy. The other side is this two numbers stands for me for successful prevention. If we would be physical active and walk 10,000 steps a day, we would not contract chronic diseases. And physical activity is the most powerful anti-diabetic activity we can do. And the 1,000 mean if you have diabetes and you only walk 1,000 steps more than you normally does, and it doesn't matter how much you're walking, but you increase 1,000 steps, it's about 600 meters. It lowers postprandial blood sugar by 1.5 millimole. This is twice as much as 1,000 milligram of metformin are doing. So this is actually very powerful information, because you see how you can tackle your glucose level by physical activity. Unfortunately, we are not doing it anymore because we see it as quality of life not to be physical active. So the reality is actually the reality is bad. The reality is not very successful, um, because we are not using the power of physical activity anymore. And if I would ask the question the other way around, how many hours per day we are physical inactive, especially in the Western environment, the answer would be 23 hours and 40 minutes per day we are physically inactive. We are a lazy species. And this is something we can change. Every one of us can change to prevent diabetes from developing. But we are physicians, so we have to focus on understanding the pathophysiology. And what you here see is healthy. So it's a young woman, actually high normal A1C, and the green arrows mean she's eating something, and it's done with CGM, so 1,440 measurements of glucose per day. And the purple line is glucose. And you see nothing. She has a flat glucose curve, and this is someone who's very healthy. She's very insulin sensitive. So she needs maybe 1% of the insulin the pancreas can produce to regulate their blood sugar. But here is her father. Yeah, truly her father, actually having a better A1C than the daughter, because here it's the black spots where he's eating less carbs, the father. But you see there is a fluctuation of glucose. And this is going in the hyperglycemic range. Maybe this was breakfast, this was lunch, and here was no physical activity or anything. There's no treatment, of course, because it's A1C of 5. And today we know that this is someone who's very insulin resistant. So this father needs about 80% of the insulin the pancreas can produce to regulate blood sugar. And this is a difference to the daughter. And this is a difference what makes him contracting a high risk of getting diabetes and cardiovascular disease and kidney disease as well. Unfortunately, we don't find them because we cannot use a sensor for screening because they are far too expensive. This will change over the next years. Yeah, I'm optimistic that in 3 years from now we have sensors for 2 weeks for $1 or less, but we don't have it yet. And but what are we learning? If we think about prevention and treatment, we should lower the fluctuation of glucose variation, and this will be of benefit for the outcome of the people. And it's the same for prevention and care. So now, again, have in mind, eating a lot of carbs is the opposite from reducing the fluctuation, as we already have seen with the father. And especially is this relevant for people who have an insulin resistance? And the main driver of insulin resistance is accumulation of fat in the liver. So bringing this together, you see here the pathophysiology over 80 years getting diabetes. The daughter is about here and the father is about here, but 80% insulin resistance. And this is developed by the visceral obesity. This was our state-of-the-art knowledge up to 5, 6, 7 years ago. And today the hepatic fat, so the MAFLD, is coming into the game. And you see, it's a little bit before the presentation of the father, hepatic fat increases and then continuously goes on. And also in the case of the father, it was the consumption of carbs and fried carbs. So here diabetes starts, and here we diagnose diabetes. So if we look at this picture, we are coming far, far, far too late to treat diabetes because we only have the option here at the end. We have to think, can we tackle the people in this red paradigm to do prevention of diabetes, reduce insulin resistance, lower also high normal glucose level, reduce visceral obesity, and maybe reduce the fat in the liver. So the interplay between visceral and hepatic fat is driving the risk of getting diabetes. The visceral fat, by releasing more than 800 known peptide hormones, um, and these peptide hormones contract or increase the risk of nearly any chronic disease. The hepatic fat as part of the twin cycle hypothesis, so accumulation of fat in the liver increases insulin resistance in the liver, releases more free fatty acids, and those are accumulated in the pancreas. They initiate an inflammation in the pancreas, and the insulin resistance in the liver actually releases more glucose out of the liver. So in an insulin resistant stage, more glucose coming out of the liver, and the inflammation generated in the pancreas destroys insulin secretion. So we have a two-hit hypothesis or twin cycle contributing to diabetes risk. And there is a very interesting observation, description also from Taylor a few years ago, showing that fat in the liver and fat in the pancreas destroys beta cell function. But the opposite also works. Removing the fat of the liver removes fat out of the pancreas and restores beta cell function. And this, at the end, can be a remission of diabetes. And I must say, in my eyes, this is very, very hopeful and promising information. This is very, very exciting information, I must say, because we have the option to lead to a remission of I don't want to use the word cure, but at least a remission of type 2 diabetes. And this can be relevant for millions of people worldwide. And if I would stand in front of you, I would now ask, how can we remove the fat out of the viscerum? And the answer would be physical activity. Physical activity, physical activity. But how can we remove the fat out of the liver? And the answer is fasting. If you fast for 2 weeks without eating anything, then you totally can abolish the fat in the liver. A little bit depends on how much fat was in the liver, but over 2 weeks, you can remove about 200, 250 grams of fat in the liver, as well in the pancreas. And in my eyes, this is the fastest gain of health you can generate for people living with type 2 diabetes. But we also have to understand the patient where diabetes is coming from. And one snapshot for this as well, here you see 380,000 patient years, and it shows you if you drink one soft drink per day, how this contributes to diabetes risk. If you drink water, there's no increase in diabetes risk. If you drink any kind of soft drink, 40%, like Coca-Cola, 40%, but the Diet Coke or Coke Zero is 60%. How can this be that the Coke without sugar makes more diabetes than the Coke with sugar? And the answer I've written here, artificial sweetener, because the artificial sweetener, there are 38 available worldwide, and 36 of them change the microbiome. So the complete set of the bacteria in our gut. If you do exercise and you are healthy and then eat over, in this study, it was 1 year, every day artificial sweetener, then you change your gut microbiome. And the problem is not that there are 14 different bacteria invading our gut. They still help us to digest. But the problem is this bacteria produce as result of their metabolism, they produce metabolites, which is a glucose molecule built to a fatty acids. And this is the same what happens for if you fry carbs. And this bacteria, billions of bacteria in our gut, and what are they doing? It's their stool, these metabolites. We incorporate them and store them in the liver. And the problematic thing in this study, it was shown if you accumulate fat in the liver, you become a non-responder to physical activity. But we need the physical activity for the visceral fat. So by accumulating fat in the liver, a vicious cycle starts who contributes more and more and more continuously to the development of diabetes. But I want to give also options what we can do. And one is smart health, where I think this will be disruptive in the way how we do prevention and diabetes care in the future. Here you see how our drugs lower A1C, how digital tools, old, middle, old, and young digital tools lower A1C. And you might say, how can a young digital tool, which normally is an app on a smartphone, lower A1C? And the answer is easy. We are in the pocket of our patient. We never have been so close to our patient than being in the pocket. And every one of us is taking 1,800 decisions a day. Now imagine in the right moment, with the right motivational strategy, with the right content, an app would set impulses to modify only 10 out of the 140 or 180 lifestyle-related decisions per day. But is doing this over the period of 1 year. This might be translated to 10 kilograms of weight reduction. And so 1,800 decisions is everything what we are doing. 140 to 200 are related to our lifestyle. And 10 would be enough to change lifestyle sustainably. And I think this is a very cool information for prevention. So IDF will focus on this and foster strategies for prevention using digital tools in the future. And there are good examples, for example, here in Germany, apps where you can scan your meals by using AI and it qualifies and quantifies what you're eating, but you're not getting blamed for what you're eating, but the information is used to help you, to encourage you to eat the next meal healthier, and also others using this glucose sensor. In my eyes, this is diabetology out of the pocket of the patient, using the sensor data, comparing it with a swarm of other patients, and making clear recommendations how to treat or prevent diabetes by the use of AI, by analyzing the glucose curve. I know that this is not everywhere available. It's actually very limited available currently, but this will change and we will have the opportunity, and every one of us will experience this with very cheap sensors. And the advancement or the quality of care will not be the sensor. The quality of care comes, what are we doing with the data? And how can we translate this into an added value for our patient? And at the end, I want to come to the fasting again. I mentioned fasting, in my eyes, is the most powerful way of preventing diabetes by abolishing the fat in the liver. And we know if you eat less, you live longer. And it's good for the brain, it's good against diabetes. Maybe we could say eating for 2 weeks nothing is even more healthy. And there are very interesting studies actually from the last 50 years. And I was very recently in India. The Hindus do this regularly. Yeah, 9 days, 14 days, up to 5 weeks water fasting. So only drinking water. And this is possible. This is actually, it's easier not to eat anything than to eat a little bit if you are through the first 3 days of fasting. So in my eyes, total fasting or water therapy, water diet is the fastest gain of health. You lose a lot of weight, but the enormous outcome is you abolish the fat in the liver and you have a reset of your microbiome. And here you see an MRI spectroscopy picture from someone before fasting, and the cloudy stuff here in the liver, it's the fat. And this is after fasting. And I think this shows the power of fasting, the power of water therapy, the power of 2 weeks only drinking water. As president of IDF, I have installed a group talking about fasting and diabetes. And in a few days, actually, we will release a chapter for the new ASD 80A guideline on fasting and diabetes. And the new DAR guideline will address fasting and diabetes. And in the World Congress in Qatar in 27, we will release an IDF guideline on fasting and diabetes. And this is the recommendation for the water therapy or water diet. It's a proposal in the moment. The experts, more than 120 experts worldwide, are looking into this. And this group is led by Mohamed Hassanain and Daniela Koppold. And here you see examples of the different um, fasting strategies. And here you see the water fasting or water diet as well, but 19 other different fasting styles for diabetes. There's another group, Prevention of Obesity and Diabetes in Adolescents, led by Ines Schaltut, who just has released a public health campaign. There's a group for type 5 diabetes, IDF has initiated, and this group addresses the new type 5 diabetes, which in the past was named as the malnutrition-related diabetes. There's another group about type 4 diabetes, especially gestational diabetes, a group working in AI and diabetes. So developing guidelines for responsible use of AI in diabetes care, and cooperation with WHO, ADA, and EASD to harmonize the criteria how to diagnose diabetes and how to assess prevalence of diabetes as global organization with one standards. So preventing type 2 diabetes, why, when, and how? Why? Because we can prevent a lot of complications and can generate a lot of cardiovascular risk reduction when, at any time, if you think about this. And how physical activity, fasting supported by digital intervention, I think is a very good strategy in most of the environment worldwide. I know that this is not available everywhere, but especially in low and very low income environment, this could be available because fasting may not cost anything. Physical activity is not costing anything. And digital infrastructure often is good. As president of IDF, I have three goals: to be in the diary or the brain of the politician, to be in the pocket of the patient, and in the heart of every healthcare professional. And the first one we will reach by the Global Diabetes Index. So developing an index by asking healthcare professionals and patients once a year about the perception of the quality of diabetes care worldwide. And this will be translated into an index to make diabetes care in Myanmar, Yemen, Helsinki, Wisconsin, and Argentina comparable. And by making it comparable, we hope it builds a momentum to invest in improvement of quality of diabetes care. Secondly, to be in the pocket of the patient. And you can imagine using digital tools with a free diabetes education program from IDF, accessible everywhere in the world. This would be a big gain. I again know that not everyone has a smartphone, but the number grows very fast. And having free access to evidence-based diabetes education could be a big jump ahead. And finally, a fellowship program of the International Diabetes Federation. You as healthcare professional, you as colleague could become fellow of the International Diabetes Federation. And by this, building a community of colleagues who are passionate to improve the quality of diabetes care. I would be happy if you would follow some of these channels from me as president of the National Diabetes Federation, where I report about this activity and invite you to participate. At the end, we should join our forces. We should use the energy to work together. We should think about what we can do in our environment, but with our partners, with stakeholders, with politicians and policymakers, how to improve the quality of diabetes care. Let's come back to this faces of people living with diabetes. They deserve a better life, and they deserve that diabetes would have been prevented for them much earlier. Today we know how to do it. Let's do it. Let's overcome barriers. Let's discuss strategies. Let's implement them. Let's try out strategies for prevention to finally help our friends, colleagues, our community to walk away from diabetes. Thank you very much. Thank you for your attention. I thank you for your commitment and your action.